Asthma Grand Rounds. We have an exciting Asthma Grand Rounds today. We have Peggy Lai. She's an associate professor at Harvard Medical School, and she's within the Division of Pulmonary and Critical Care Medicine at M.P.H. She has secondary appointments in the Monaghan Institute at M.P.H. and the Department of Environmental Health at the T.H. Chance School of Public Health and at Boston Children's Hospital. Peggy's research group focuses on research at the intersection of environmental exposures, the microbiome, and chronic lung disease. Her lab work in she worked collaboratively in both US-based and global projects, spanning the spectrum of translational research, observational studies, and randomized clinical trials. She is the recipient of the David Bates Award of the Assembly of Environmental Occupational and Population Health of the American Thoracic Society. She's on multiple committees in international health and education, and she recently won the 2024 Ann Klebanski Excellence in Mentoring Award. And today, Peggy is going to share with us the role of viruses in asthma development and severity. Peggy, thank you so much for joining us. And just to remind everybody, if you'd like to get CME credit, please write to my assistant at eisraelasst, EISRAELASST at partners.org to get CME credit. And Peggy, thank you so much for joining us.
Great. Thanks so much for such a kind introduction, Elliot. So I'm very excited to talk about the role of viruses in asthma development and severity this morning. These are my disclosures listed below. So this is quite a big, meaty topic, and one could spend hours talking about it. So I thought what I would do today is really focus on human observational and clinical trials where available. And then sort of like break it down to three main topics. And so I think to understand whether or not early life viral infections cause asthma, it's important to understand, can you actually diagnose asthma in early life? And so that would be the first thing I would talk about. And then talking about, the question of, do early life viral infections cause asthma? And then ending with which viruses cause asthma exacerbations. But before even getting there, I just wanted to kind of describe the landscape, because again, there are many different human respiratory viruses, and although some of them are the ones that make the news, in fact, there's many different ones. And so the vast majority of these are RNA viruses, which tend to mutate rapidly. All right, so asthma is pretty hard to diagnose in early life, especially in the preschool years. There's really no set diagnostic criteria. And some have said, well, there is this phenomenon, a clinical phenomenon called preschool wheezing. So can we use that as a surrogate for who is at risk for developing asthma later in life? This is challenging, though, because there are children with preschool wheeze who go on to not have asthma. And so how do we understand this phenomenon? I think this is a pretty nice population-based cohort study based in the UK that I think can shed some light on this. And one of the nice things about doing research in the UK is that they have a more unified health system compared to the United States. And so using electronic medical records, it's possible to actually understand some of these things that require a long follow-up. And so in this particular study, the researchers relied on two different EMR databases. So one is the Clinical Practice Research Database, which is composed of UK primary care practices, representing about 10% of the UK population, or 11 million patients. And amongst these 11 million patients, about 1 million were preschool children. And the nice thing about it is that in the subset of these patients, you're able to link the medical records of the mother with the child to look more globally at other risk factors. And so this database was combined with a hospital episode statistics data, which records all emergency room visits and inpatient hospitalizations. And so based on these two databases, a number of questions were asked based on the different levels of the cohort. And so first, what is the burden of preschool wheeze? And so of the 1 million children, about 69,000 or 6.8% had at least one documented wheeze event requiring presentation to an outpatient practice. And 30% of these wheeze episodes were associated with a viral infection. Okay. And then of these children who had at least one preschool wheeze event, how many go on to develop asthma? Surprisingly, it's only about 35% of these children who go on to develop asthma. Although again, this cohort was a little bit smaller because they had records continuously until the age of 8. And then taking this subset of children, they were then linked to their mother's medical records to understand additional risk factors. And so on the maternal side, if your mother had a history of asthma on a controlled medication or atopy, you're at slightly higher risk of developing asthma later in life. On the child side, a history of prematurity or atopic diseases was also associated with the risk of later asthma development. And then further delving into the wheeze characteristics. And so what kind of wheezing is more high risk? Well, the first wheeze after the age of 3, frequent wheeze events. So the threshold was 4 or greater in the preschool years, and also severe wheeze. And so a wheezing episode that required you to visit an emergency department or be hospitalized. And then finally, wheeze that first occurred in September. I had a hazard ratio that was similar to a history of atopy in the child or the mother. And so what's up with that? Why is it so important? Well, to break it down a little bit further, let's look at this figure. And so on the x-axis is the month of the year in which the wheeze event occurred. And let's focus on the right axis first, which is the monthly prevalence of wheeze reporting. And this is the dotted line. And so you can see that overall, the wheeze events are most common in October, November. However, when focusing on these blue lines, and then this left axis, which is the risk of progression to asthma, you can see that in the overall cohort and those that had mother-baby records linked, that if you wheeze in September, you were much more likely to progress onto asthma. And so why is that? Well, in the UK, rhinovirus infections peak in September and RSV peaks in October. And so if you differentiate, what was the cause of the wheeze from the medical record. And so the blue line is infection. And so the physician documented a concurrent infection associated with the wheeze. There's a peak there. And so one can infer that it's a viral infection associated wheeze that actually increases your risk of going on to develop asthma. So to summarize, only about 35% of children with preschool wheeze actually go on to develop asthma by the age of 8. And the preschool wheeze features associated with higher risks, including more frequent wheeze, more severe wheeze, and requiring hospitalization or an ED visit. And we infer viral infection associated wheeze. So let's dig a little bit more into this viral infection associated wheeze. And let's focus on first one of the best studied viruses for this question, which is RSV. And so this is one of the earliest reports that severe RSV infection in the first year of life is associated with later asthma and diagnosis by age 7. And so this was a Scandinavian study. And the hypothesis here is that early life severe RSV infection is associated with asthma risk. And so this was a case control study of children recruited in infancy and then followed up until the age of 7. And so 47 infants hospitalized with RSV and bronchiolitis in the first year of life were followed along with a age-matched control, healthy infant control. And they had longitudinal histories and physicals performed by experienced pediatric allergists. RSV infection was defined as severe if the child was hospitalized with RSV bronchiolitis and they had a positive test for RSV. And then asthma diagnosis was defined as greater than 3 episodes of physician-verified wheezing. And so in this plot here, the children were subdivided into 4 different groups based on whether or not they had family history of asthma and also whether or not they had RSV bronchiolitis early in life. And so you can see that the children who had a history of RSV bronchiolitis had a much higher risk of developing asthma later in life. And in fact, these are the risk ratios. And so whopping 9.2 relative risk for cumulative asthma if you had RSV early in life, higher for atopic asthma and also for other allergic diseases. Now, this is obviously a pretty limited design. This was a case control study and only univariate analyses were performed. But these eye-popping relative risk suggest that maybe there's more to be seen. And so there are several other large EMR-based studies between this study in recent years I won't go through because I'm going to jump to sort of the most robust study focusing on this, in fact, this question. In this study, the hypothesis of the investigators is not having RSV infection of any severity protective against later asthma. And so this was a large population-based cohort study um, where full-term healthy infants less than 4 months were recruited from 11 different pediatric practices in Tennessee. And then they were followed longitudinally, but they're followed in sort of a different way than EMR-based studies. So number one, there was really a lot of surveillance actually for any viral infection, but in particular RSV. And so every 2 weeks, there was active surveillance where the parents were contacted and asked, has your child had any symptoms of respiratory infection? And then there was also passive surveillance. And so when the child had an infection, the parents would call the research team. And also every time the child presented for any outpatient visit, they were also assessed for signs of respiratory infection. And then if there was, then a nasal swab was obtained for RSV by RT-qPCR. But then also to assess missed viral infections. At the age of 1, an RSV serum antibody titer was also performed. And their primary outcome was current asthma diagnosis at the age of 5, which is based on a physician diagnosis of asthma or use of any asthma medication. And because it was current asthma diagnosis, also the use in the past 12 months of any asthma, steroids for asthma, healthcare utilization, or current asthma symptoms. So by year 1, about 54% of the children had evidence of an RSV infection. And when looking at risk factors for RSV infection, there was Black, non-Hispanic race and ethnicity, birth by C-section, daycare attendance during infancy, and also the presence of another child less than 6 years at home when the child was an infant. As for their primary outcome, which is current asthma, and so remember, their primary exposure was not having RSV infection. And so you can see that in both an adjusted and adjusted analyses, actually not having RSV infection in the first year of life was associated with a protective effect against asthma diagnosis at the age of 5. They also asked the question, is this asthma this protection associated with protection against atopic or non-atopic asthma using 2 different definitions. So either skin prick testing or specific IgE or a report of atopic diseases. And they found the same signal. Actually, the effect sizes were very similar. And so not having RSV infection of any severity in the first year of life was associated with a reduced risk of non-atopic asthma. And so going back to our first question, do early life RSV infections cause asthma? Well, I think the data is pretty robust in showing that if you don't have RSV infection of any severity, whether you're hospitalized or not, you have a reduced risk of childhood asthma diagnosis. However, as I mentioned, the INSPIRE study and really all the other studies were observational studies. And so there are 2 possible explanations. Of course, one is RSV infection in the first year of life causes asthma, but then also it's possible that there is an underlying genetic susceptibility to both RSV infection and asthma that cannot be distinguished even with causal inference approaches without a clinical trial. Okay, so now that was a bit of a whirlwind, but a lot to cover today. Let me move on to the second virus, which is human rhinovirus. And so, do early life rhinovirus infections cause asthma? Well, this is a little bit trickier actually, because rhinovirus infections are very common. And so, in this study, the investigators based in Madison, Wisconsin, hypothesized that it's a wheezing associated viral illness in early life that is a risk factor for age 3 wheeze. And as I mentioned, preschool wheeze is an imperfect surrogate for later asthma. But let's talk about the study a little bit more. And so in this population-based birth cohort study called COAST, um, 275 full-term infants who were high risk of future asthma development because their parents had to have either atopic diseases or asthma or followed until the age of 3. And then, unlike the INSPIRE study, besides looking for symptomatic infections, they also looked for asymptomatic infection. And so nasal samples were collected routinely at 2, 4, 6, 9, and 12 months, but also when the child was sick. And when the child was sick, a respiratory symptom scorecard was administered. So this is a standardized survey to assess for the severity of symptoms, as well as whether or not the child had wheezing or not. The nasal samples, regardless of symptom severity, were sent for PCR for looking at a variety of different pathogens, including RSV, rhinovirus, influenza, parainfluenza, and also other picornaviruses. And then the primary outcome, as I mentioned, was wheezing in year 3 based on the parent survey. And so what did they find? And so in this plot, which is a little bit complex, on the x-axis is sort of groups stratified by symptom severity. And so you had children who had routine nasal swabs collected, who had no symptoms at all, but then also nasal swabs collected during the time when the children were very symptomatic. And so higher score means more severe. And on the y-axis is the viral recovery rate. And so you can see sort of a few simple observations right off the bat. And so the more symptomatic you were, the more likely you were to have recovered one of the tested viruses. And so 78% if you had very severe symptoms. However, even in the absence of symptoms, actually 31% of the nasal swabs are actually positive for one of the tested viruses. And so that's the first point, is that there's actually a lot of asymptomatic viral infections. The second observation is that you see a lot of red. And so red corresponds to rhinovirus infections. And so you can see that right off the bat, it's the most common respiratory infection in this birth cohort. And then thirdly, you see that as symptom severity increases, the proportion of dark blue also increases. And so the dark blue actually corresponds to RSV infection. And so symptom severity increases the chance of positive virus detection. Although rhinovirus is the most common, RSV is most likely to cause severe symptoms during the infection. So these are characteristics of the infection in the first year of life. But what about asthma risk? And so first off, there are actually no differences in the number of viral infection in the children with or without year 3 wheeze, which, as I mentioned, was the imperfect surrogate for later asthma diagnosis. But what was interesting was the severity of symptoms. And so this is a bit of a complicated table, but here, the children were stratified by how sick they were, from no symptoms at all to moderate and severe symptoms, but without wheezing, to moderate and severe symptoms with wheezing. And so when we look at the unadjusted and adjusted odds ratios, you can see that if you had symptoms, so you were more likely to have year 3 wheeze, but if you had symptoms with wheezing, then that was most predictive of year 3 wheeze. And so viral infections that are very symptomatic with moderate to severe illness and wheezing in infancy are associated with year 3 wheeze. Now, as I kept on mentioning, though, year 3 wheeze is not the same as asthma. Oh, sorry, actually, let me just mention, when looking at the different pathogens, so comparing RSV, rhinovirus, and all the other viruses, you can see, surprisingly, that wheezing associated with rhinovirus had an odds ratio of 10 of year 3 wheeze compared to RSV or really any other viral infection. And so it seemed, at least in this preliminary follow-up study of the COAST cohort, that rhinovirus associated wheezing had the greatest risk for year 3 wheeze. All right, and so again, to better understand what does this mean for asthma, the COAST study birth cohort was actually followed up until later in life when asthma can be more definitively diagnosed. And based on their first study, they hypothesized that early life rhinovirus-associated wheezing illness was associated with later asthma diagnosis. And so the same cohort was followed up for a longer period of time to age 6. There was actually pretty minimal loss to follow-up. And then viral infection diagnosis was as described previously. And then their primary outcome now at this point in time was actually asthma at age 6, so not just wheezing. at age 3. And this was adjudicated by 4 experienced physicians based on efficient diagnosis of asthma or the current use of albuterol, a daily controller medication, or a recent prednisone course for asthma. Looking here in this plot on the x-axis is whether or not there was a viral infection associated with a wheezing illness on the x-axis, stratified by RSV, rhinovirus, or both pathogens. On the y-axis is the proportion of these children with asthma by the age of 6. And so you can see, we've already established that RSV associated infections are a risk factor for later asthma diagnosis, but rhinovirus has a much higher odds ratio of being associated with asthma at age 6. And so again, going back to sort of our question, do early life viral infections cause asthma? Well, viral associated wheezing illness in early life is a major risk factor for future asthma diagnosis. And it seems that there's differences in the pathogen. And so rhinovirus associated wheezing seems to have a greater risk for causing later asthma than RSV. However, again, as I mentioned, these are observational studies. And so even as a birth cohort study, you can't really distinguish between a shared genetic predisposition or a causal relationship. However, I think all this research brings up an interesting question, which is, can we prevent childhood asthma? Well, I think in the past 2 years, with the approval of a very effective RSV vaccine, that is possible. And so current guidelines now for this RSV vaccine are to vaccinate pregnant women their last trimester if their infant is, projected to be born during RSV season. And we know from existing studies that maternal vaccination leads to, at minimum, 6 months humoral immunity for the infant. And so in these RCTs, if there is longer follow-up of the infants, you can answer this question. Number one, is this a genetic susceptibility that is unmasked by RSV infection, or does early life RSV infection actually cause later asthma? But then even more importantly, there's the implications in that there could be primary prevention for asthma based on vaccination. And so I think that's one area that's, pretty promising and exciting. However, as we talked about, rhinovirus is also a very important infection, but rhinovirus vaccines are probably going to be very difficult to develop because, again, there's many more serotypes. And the vaccination, attempts at creating a vaccine have really not been successful. And so a different approach can be taken. And so there is actually a primary prevention trial for asthma based on omalizumab, based on several observations. And so number one, it's known that IgE actually impairs antiviral immunity. And early studies have suggested that administering a monoclonal antibody against IgE, omalizumab, actually can restore the interferon alpha response to rhinovirus. And so the PARC study, the overall PI, whom is Wanda Fipatenicol at Boston Children's Hospital, is an ongoing randomized controlled trial where toddlers at high risk of developing later asthma based on family history are randomized to get omalizumab versus placebo, with the primary outcome of asthma diagnosis. And so again, a second different approach to asking the question, can we actually prevent future asthma? Okay, let's move on to the last part of the talk, which is the question, which viruses cause asthma exacerbations? And this is actually pretty hard to study. And so I'll focus on the meta-analysis, but acknowledging that there's a lot of limitations. And so number one, many different studies have looked at, which viruses can we detect during asthma exacerbations, but with a few caveats. And so some viruses are very seasonal. The season also varies by geographic region and also the type of testing, right? So some studies only look at one virus, such as RSV, for example, whereas others use a panel approach. And so there are many limitations, but I do think it's worthwhile at least to look at this meta-analysis. And so the inclusion criterion was any human study of any design, whether it's cross-sectional, prospective, cohort-based, or case control studies, where the primary outcome was asthma exacerbation, and some testing of respiratory secretions, whether upper or lower, was performed. And these authors included all types of testing from PCR to culture. And so 63 studies were ultimately included. And despite the many caveats, I think it is interesting at least to look at their results. And so stratifying adults versus children, the most common virus detected was rhinovirus, and this was true for both adults and children. Although the next four most commonly detected viruses slightly differed between adults and children. However, as we talked about, many viral infections are not symptomatic. So I wanted to put a pin on that last meta-analysis and actually take a few minutes to talk about this study here, which was trying to ask the question, how often are respiratory viral infections symptomatic? And so to do this, they recruited actually several different populations from the general community in Manhattan. And so this is pretty heterogeneous. And so they had some children attending daycare who were recruited along with their siblings, as well as their parents. They also recruited separately students and teachers from a local high school. And then they also recruited physicians from practicing in either a pediatric emergency department, an adult emergency department, or just providing inpatient and outpatient care. And so again, to answer this question, you can't just, test people when they're sick, which is unfortunately the vast majority of asthma studies. What they did, which is very resource intensive, but also with a higher participant burden, is that once a week, they had the participants actually collect nasal swabs along with a concomitant illness report. So weekly, for up to 2 years, participants would collect these nasal swabs and send it in, as well as fill out a weekly survey assessing for upper and lower respiratory symptoms, as well as influenza-like illnesses. And then these nasal swabs then underwent a multiplex influenza panel that was pretty broad, looking at influenza, RSV, parainfluenza, human metapneumovirus, rhinovirus, adenovirus, and many of the non-COVID coronaviruses. As an asterisk, this study was published in 2019, so predates the COVID-19 pandemic. And so the first important thing to note is that only 45% of the viral infections were actually symptomatic. And so the flip side of that is actually the vast majority of viral infections, so 55% actually had no symptoms whatsoever. And these are participants who are filling out a weekly scorecard, so they were very attuned to how they were feeling. The second interesting thing is that only 67% of upper respiratory infections or influenza-like illness symptoms actually had a detectable virus. And so this, could be explained by different things, including, viruses that we don't have assays for. But which virus was the most symptomatic? And so this is a bit of a complex plot, and there are many bars. And so each bar represents one of the different populations that were recruited for the study, whether it's the high school teachers and their students, or the daycare children and their siblings and parents. But the gray bar represents the average overall. And so the height of the bar represents the proportion of infections that are symptomatic. And so you can see that influenza infections and actually human metapneumovirus infections were the most likely to be symptomatic in this very diverse cohort. When then looking at whether or not adults versus children were more likely to be symptomatic, this is what they found. And so the green bar are adults without children, blue bar are adults without children, and the orange bar are children. And so if you focus on upper respiratory symptoms alone, actually adults, especially adults with children, were more likely to have symptomatic infection compared to children. So you might say, okay, that's a great study. The vast majority of, viral infections are asymptomatic, but maybe asthmatics are different. Maybe asthmatics are more likely to be symptomatic. And so how would we actually answer this question? And this is challenging because to do this, you actually have to experimentally infect participants so you know when the viral infection started, and that's challenging to get through an IRB, but there are actually a few of these experimental studies. And so in this study, this was an experimental studies where 20 healthy adults were recruited. They were tested for atopy with IgE or skin prick testing. They also had a methacholine challenge to prove that they did not have asthma. And then also 18 adults with mild allergic asthma. And then an inclusion criterion was no rhinovirus 16 neutralizing antibody. And so this just signifies that they haven't recently been infected with rhinovirus. And so all of these adults then were actually experimentally infected with rhinovirus, and they were followed daily for 14 days. And every day they were assessed for cold symptom scores, viral titers, and through a nasal swab and actually induced sputum, and also their peak flow. And it turns out that there was actually no difference in these two groups, the healthy adults and adults with mild asthma, in terms of anything, cold symptom scores, viral titer, and peak flow. And so, at least for rhinovirus infections, there's no suggestion that asthmatics or adult asthmatics, I should say, are more likely to be symptomatic. Now, I think one thing that, has been sort of missing in the literature is that, we've tested people for viral infections, but we don't know a lot about what we're sort of exposed to in day-to-day life. And so this has been the focus of my group's work, along with one of the Botanical at Boston Children's Hospital. And so this was a study that we wanted to do to understand, what viral exposures are present in elementary schools. And obviously, elementary schools would be considered, sort of a high risk environment. And so in this trial, we assessed 209 classrooms in 40 different elementary schools. And so we performed longitudinal week-long collection of bioaerosol samples in the classrooms. And the study period was from 2015 to 2019, so it predates the COVID-19 pandemic. But once we collected these air samples, which were then frozen until testing, then we developed a assay or using something called digital droplet PCR, which can absolutely quantify the number of viral copy numbers in the air. And again, we tested for a broad variety of different viruses, ranging from adenovirus, RSV influenza, to rhinovirus. And we actually did test pooled samples for SARS-CoV-2, even though it predated the pandemic, and we did not detect SARS-CoV-2 in any of the air samples. And this is what we found. And so this is a heat map, and I'll walk you through it because it's a little bit busy. And so on the x-axis is each classroom. And so again, we had over 500 samples, but each column represents one classroom. On the y-axis is the different virus that was detected. And so if there's a green box, it means that we detected that virus arranged from most prevalent to least prevalent. And so you can see that the most prevalent virus that we detect in the air of elementary school classrooms is rhinovirus, followed by coronavirus OC43, which is a coronavirus that causes the common cold, and enterovirus. However, importantly, we also detect many viruses that are most likely to cause either symptoms or severe respiratory illnesses. And so this includes RSV A and B, a metapneumovirus, and influenza virus. And in fact, on average, we detect 3 different respiratory viruses in the air of elementary school classrooms, although there's a broad range up to 13 different viruses in some cases. And so all this is to say is that we are actually exposed to a lot of viruses in day-to-day life, with rhinovirus being the most common, and perhaps that's the denominator there. And so to summarize this last part of the talk, which viruses cause asthma exacerbations? So rhinovirus is the most commonly detected virus during asthma exacerbations. However, I would like to highlight that rhinovirus exposure is likely the most common virus exposure, although we tested this in elementary schools because they are the highest risk areas. It is likely that this pattern is repeated in other public places, at least. Most rhinovirus infections are asymptomatic, and asthmatics do not seem to have more respiratory symptoms than healthy controls when infected with rhinovirus. And so, again, to conclude, how do you diagnose asthma in early life? It's challenging. Some have used this clinical phenomenon of preschool wheeze as a surrogate for later asthma risk, but only about 35% of children with preschool wheeze actually progress to asthma. And as for the question, do early life viral infections cause asthma? Well, we know that RSV infection of any severity is a risk factor, and that rhinovirus-associated wheeze is also a risk factor. Other viruses are not as well studied, and it is still unclear if the RSV studies and rhinovirus studies are related to underlying genetic predisposition versus saying that viral infections in the first year of life are actually causal. But again, as I mentioned, with the approval of a very effective RSV vaccine, this question may be answered with these children are followed up. But again, it raises very exciting sort of ideas about whether or not we can actually prevent asthma to begin with. In terms of the question, which viruses are most commonly detected in asthma exacerbations? Well, rhinovirus is the most commonly identified virus, but it also is the most common exposure. And then again, I would like to highlight that many viral infections appear to be asymptomatic. And so I think, this is an exciting area, I think, because again, there's, just areas and questions that really have large public health implications. Obviously, the first one being, can we actually prevent asthma in high-risk children, either via effective vaccines like the RSV vaccines or with the ongoing trials focused on omalizumab. In terms of, the pathogen side, because again, many studies have focused on the host, but not the pathogen. I think, it's important to better understand which viruses and virus-associated virulence factors cause more severe disease. And so I suppose one of the silver linings of the COVID-19 pandemic is that in clinical use, there's much broader respiratory viral panels that are being administered. And so population-based studies can be done using existing EMR data. But also that we need to better understand the viruses. And so the vast majority of these studies have simply used PCR to detect the presence, absence, or even the viral load, but not actually delve deep into virulence factors. And so to do that requires sequencing. And again, now there are techniques where it makes it much easier to sequence viruses. And so I wanted to acknowledge again the support of many different collaborators on my lab and funding for the last study that I discussed. And I'm happy to take any questions. I'm gonna stop sharing now.
Okay. Peggy, that was a wonderful talk and a wonderful overview of that. So we have a question. Did I understand that in an experimental setting, asthmatics with viral respiratory tract infection did not experience more symptoms than non-asthmatics? Respiratory symptoms? Seems hard to believe given the myriad asthma exacerbations with severe lower respiratory symptoms caused by viruses.
Yeah, so again, I think to really answer this question, right, like you need to know when the viral infection started. And as I mentioned, there, some of the studies that I mentioned, like many viral infections are asymptomatic. And so to really study this, you actually need to infect people with viruses so you know when that viral infection started. And, there's obvious, IRB related issues, right? Because, you're experimentally infecting people with viruses, and people are always more worried. And so the existing experimental infection studies that I've seen have only used very mild viral strains, right? And so rhinovirus 16 was the one I mentioned. The non-COVID coronaviruses have been used in these experimental studies, and at least, in comparisons of, people with mild asthma versus healthy subjects, there's surprisingly no increase in symptoms, or viral titers or shedding or peak flow. Now, I think, ideally, if you weren't worried about, protecting human subjects, you could test a wide variety of different viruses, including even RSV or influenza, but I think it would be impossible to do this safely, I think. But I think I'm just raising the possibility that even in asthmatics, it's not necessarily true that all viruses cause more severe symptoms in asthma. And again, I think the deficit, I think, is in our ability to study this question in a really rigorous way.
Okay. Another question is, have any studies tested for shared genetic features among people with early life RV, RSV, and/or asthma, as in to test for evidence of your non-causal hypothesis?
Yeah, and so, the investigators that are part of the COPSAC group in Copenhagen. So, again, many of the European countries have really nice, sort of access to health data on a population-based level. And so the COPSAC investigators access actually a twin registry based Danish twin registries where, and I can, if you email me, I can send you the data where they felt that based on their analysis of twin registries, that there is no evidence for an underlying genetic predisposition to RSV infection and asthma. But again, I think, you know, it's just challenging, right? Like to really definitively answer the real question, which is, does RSV infection in first year life cause asthma later in life? Number one, I think people would feel most comfortable if there was actually a randomized controlled trial, right? And then number two, you need a long duration of follow-up. And then you need an effective intervention to prevent infection. And so, as I mentioned, I don't think that was really possible to do using these sort of, experimental design until the RSV vaccine trials, which are very effective. And so, my suspicion is that, in 4 or 5 years, when these children are of an age where you can actually diagnose asthma with confidence, we'll see studies showing that. But Adam, if you send me an email, I can send you the study from the COPSAC group.
A question I had was in the COAST study seems to suggest that rhinovirus is the causative virus, yet the England study really suggested it was RSV in terms of association with asthma, at least the way I understood it from you. Is that correct? And which one then are we seeing differences across countries and populations?
Well, so number one, so the first study that I presented, based on the UK database. So I'll just say it's inferred, right? So because it's a database study, because not every child when they were sick with wheezing was tested for viral infections, the authors, and maybe me too, was just inferring. But again, I think there is geographic differences in which viruses are detected in asthma. And so the meta-analysis that I mentioned, and again, I can send you the paper if helpful. So there's actually geographic variation about, which pathogens are detected in the respiratory secretions of patients with asthma presenting with exacerbation.
Okay. Another question is, did the dramatic decrease in asthma exacerbations in children and adults during the COVID pandemic with widespread masking support evidence that viral infections commonly trigger asthma exacerbations throughout the year?
Yeah, I mean, I think what I presented, which is that, viral infections are not always symptomatic, you know, doesn't contradict, sort of the idea that viral infection can also be, a cause of asthma exacerbations as well. I mean, I think perhaps again, one of the silver linings of the pandemic is to show that number one, like you can prevent viral infections with very simple measures, right? Like masking and hand washing, et cetera. It's just, at least in this country, it's not politically viable.
It following up on that. So the pandemic was in 2001, right? 2021 rather, and 20. So will we be seeing data soon that might look at or suggest whether the decreased viral infections that happened during the pandemic were associated with the decreased development of asthma? Has anybody started to do that work that you're aware of?
Uh, I hope so, because again, like this is again like a natural experiment, right? And so um, I think well, you would need variation, right? Because again, you want to have a comparison group. I think that's the question is if one were to design such a study, you would need a comparison group. But
The United
that
States might offer that one, right? Amongst different states.
Yeah, and so there are variability, but again, we also know that, amongst different states, there might be differences and healthcare access, and sort of population demographic difference and things like that. But I'm sure someone very clever is already thinking, as you have, that this was an opportunity to understand, right? Or I guess, you could do sort of a time series study to understand, like, children born during the pandemic, do they, by comparison to prior years, have a lower rate of asthma? Again,
Yeah.
I think you can infer such things.
Right, right. Another question is, do you think of asymptomatic isolates of virus evidence for colonization as we do for bacteria, distinct from infection?
I think the respiratory viruses, unless you're immunocompromised, do not colonize you. They get cleared. Um, it might be different for other viruses. And again, I mean, this is why the NIH also started the human viral program last year, is because we, in general, know very little about viruses. Part of the issue were technical challenges with isolating all the viruses. So that was one challenge. And then, part of the other issue is that there wasn't such attention paid to viruses until the pandemic. But in general, for at least the respiratory viruses that I put up in that little overall figure in the beginning, tend to be cleared if you have a normal immune system.
Okay. Another question is, could an alternative hypothesis be that viral infections and socioeconomic determinants in asthma, such as housing characteristics, increase the risk of association between them, between the viral and the socioeconomic determinants?
Yeah, absolutely. I mean, this is what the Inspire study showed, right? So that, large birth cohort in Tennessee, right? You were more likely to get an RSV infection by the age of 1 if you were non-Hispanic Black race and ethnicity. And so again, that's why, I think that before we say viral infections in real life cause asthma, we really need to have a trial or some really rigorous way of establishing causality.
Okay. I think all right. So this was really a great talk to just remind everybody that if you want to get CME credit, please write to Israel ASST at partners.org or at pwh.harvard.edu, so we can put you on the list for CME credit. And we look forward to seeing you at the next asthma grand rounds. And Peggy, thank you again. And good luck with the rest of your time here in the ICU.
Thanks. I'm going to go back to rounds right now.
Okay. All right. Take
All
care,
right.
everybody, and have a good weekend. Thank you.
Bye bye.
Bye.